Good evening, everyone. Thank you so much for joining us as we discuss Pap smear guidelines and management of cervical dysplasia. I'm going to turn everything over to Dr. Allison Gockley.
Thank you, Elisa. I hope everybody can hear me. My name is Dr. Allison Gockley, and I'm an assistant professor at Columbia University Medical Center in the Department of Obstetrics and Gynecology, and I'm a gynecologic oncologist, and I'm also the director of our lower genital tract dysplasia clinic. And this evening, we're going to be talking about Pap smear guidelines and management of cervical dysplasia. If you have any questions at any point, please put them in the chat, and Elisa will help get those questions to me as I speak. This is designed to be as helpful and interactive as possible for everyone here who is on the webinar. So please don't hesitate to ask any questions. Thank you. I have no personal or financial conflicts of interest to disclose this evening. And some alternative titles of the talk would be Demystifying the Flowchart. For any of you who have looked at the ASCCP guidelines before when trying to figure out how to navigate your patient's Pap smear results, you will know there's a lot of flowcharts. In the most recent 2019 guidelines, the main guideline article was 30 pages long and included 13 figures. And so I'm going to do my best this evening to demystify and simplify some of that into a working paradigm that we can use to take care of our patients. And the ASCCP, for those of you not familiar, is the American Society for Colposcopy and Cervical Pathology, and it's really the leading guideline generating group in the United States for how to manage Pap smears. Why does the ASCCP keep changing the guidelines? Because more information continues to become available. And there is a link here for the ACCP risk-based management consensus guidelines that were published in 2019. Definitely a good PDF to have on hand. In this link, there is also an opportunity to use decision management tools for your patient's situation specifically. So definitely something to check out when you are in the clinic taking care of patients. These guidelines, like I said, were published in 2019. And part of why this is so complicated, as you can see here in Table 1, these are all of the stakeholders who are involved in coming up with these guidelines. So there's a lot of different professionals from many multidisciplinary groups who are involved and had a stake in creating these guidelines. And a little plug here, the ASCCP app is available for your phone. Last time I checked, it was $9.99. And again, I have no financial disclosures associated with this, but this is a really nice way to have in your hand as you're seeing patients access to the most up-to-date guidelines for these patients. There is also a web application where you can go in and plug your patient's specific information. So definitely something to check out. The objectives of our talk this evening is to review HPV infection and cervical dysplasia terminology, epidemiology, and natural history. We'll then review the most recent guidelines and some challenging clinical scenarios and common questions. And again, if at any point you have something specific that you'd like to review, please put it in the chat and we'll make sure we get a chance to talk about those as well. So just to sort of zoom out for a moment, what is HPV? HPV is the human papilloma virus that's transmitted usually through sexual activity. Depending on which sources you're reading, there are 12 to 14 oncogenic strains of HPV. HPV 16 and 18 are, as I usually tell patients, the most worst actors. So they're the most aggressive strains and are responsible for a significant portion of cervical cancers. Up to 70% of cervical cancers are caused by these two strains of HPV. And this is from an article that was published in the American Journal of Obstetrics and Gynecology in 2013. And I think this is a really nice synopsis of the different kinds of HPV. So we know that there are several strains that are definitely carcinogenic. There are some that are probably, some that are possibly, and then there's what we can test for commercially. And these are the 14 that we test for commercially here. Low risk, like 6 and 11, are sometimes tested for, but not in any of these commercial tests because these are really not associated with the development of cervical cancer. 6 and 11 are especially, though, responsible for the development of low-grade dysplasia or genital warts. So how does this all start and happen? And this figure shows a little bit of how we go from HPV vaccine to dysplasia to cancer. And the development of cancer is associated with these high-risk HPV subtypes, specifically 16 and 18. And what happens is the virus actually inactivates some of the tumor suppressor genes such as P53 and RB in the host cell. And that allows accumulated DNA damage to occur. And as more DNA damage occurs, more dysplasia happens. And then eventually the dysplastic lesion can break through the basement membrane and become an invasive neoplasia. The natural history of cervical cancer is that most HPV infections actually disappear between 6 and 12 months. And those that don't have a very long time span from going to HPV infection to invasive cancer. So CIN1 often develops in 6 to 24 months, but also often regresses in a similar time frame. To get to the CIN2-3, that's usually about 2 years. And then many studies suggest that CIN2-3 can take on an average of 10 to 13 years to become frankly invasive cancer. However, the qualifying fact of this is that many patients have other risk factors that we'll talk about later that actually make this time frame potentially shorter and are important to counsel patients that this risk of progression may occur faster than 10 years. So just a word about terminology, because I will try to be consistent with how I talk about the terms related to cervical dysplasia. Many of us see on reports NILM, and this is no intraepithelial lesion or malignancy. This is a normal cytology result. Ascus is a word that we often see as a result of pap smears as well, which is atypical squamous cells of unknown significance. As a side note to that, you may sometimes see on pap reports Ascus H, which is atypical squamous cells of unknown significance cannot rule out high-grade lesion, which is a different thing and has more concern for dysplasia than just ascus. And then there's the three CIN1, 2, and 3. CIN1 is mild dysplasia, CIN2 is moderate dysplasia, and CIN3 is severe dysplasia. So there are 3 different ways that we can test for cervical dysplasia and cancer. The pap test, which was developed by George Papanicolaou, as you can see here, who was the first one to really pioneer the ability to see these cells and the dysplasia underneath the microscope and realize that this was a cervical precursor. The HPV test is the test for the HPV virus itself. And then there's co-testing, which is a combination of the pap and the HPV test. Colposcopy is something that some of you may do in your clinics, or you may refer your patients to other clinics for this procedure. And I just want to spend a moment talking about if a patient is going to go to colposcopy, what does that actually mean? And so here is a picture of a colposcopy being done. And essentially there is a microscope that is used near the perineum that illuminates and magnifies the cervix for us to be able to see any abnormalities following the application of acetic acid. And acetic acid is a vinegar solution that just dehydrates the cells so that abnormal cells appear white and normal cells appear the normal mucosal color. And so once we see the lesions, if there are any present, the standard of colposcopy as advanced by the ASCCP suggests that 2 to 4 biopsies of any abnormality should be taken, and all discrete aceto-white areas should in fact be biopsied. The protocols from which the guidelines were developed are based on the Kaiser Permanente Northern California database, which has hundreds of thousands of women that have been followed for either normal or abnormal pap smear results. And the protocols that they use, which are what the guidelines come from, were dependent on when patients went for colposcopy having 4-quadrant biopsies and an ECC. An ECC is an endocervical curettage, and that is when we do a scraping, not just sort of here on the ectocervix that we do at the time of pap smear, but when we use a sharp curette and really try to sample the endocervix to get an idea of if there is dysplasia higher up in the canal. ECC is preferred for non-pregnant patients if the colposcopy is inadequate. What does that mean? So when a colposcopy is inadequate, it means you can't see the squamino-columnar junction where the transition from the endo to the ectocervix occurs. And if there's no lesion identified and the patient is not at lowest risk, or it can be done also when a lesion is seen. In practice, I do ECC on almost all of my patients, especially, again, only when they are not pregnant. And the reason for that is by the time patients get to me, they are high risk, and I really want to know what's going on inside the endocervical canal if there is dysplasia present there. So the epidemiology, the take home from this slide is that HPV infection is very common. This is, again, from the American Journal of Obstetrics and Gynecology in 2014. And this graph shows that at this age of 20 to 24, over 40% of women have an HPV infection of a high-risk strain. And you can see that that varies anywhere from, 20 to 40% throughout the course of a woman's reproductive life here. And what is important about that is while the infection is common, dysplasia is actually uncommon. When we look at some of these large databases, CIN1 is diagnosed in only 4% of women, and CIN2 is diagnosed in 2 to 3% of women. And so this has implications for how we risk stratify and how we think about patients. But I think it's very important to keep in mind when you're counseling patients that basically if you have had sex, you have come across a strain of HPV, and this does not mean that you will have dysplasia. However, cervical cancer remains a large problem. It is the 4th most common cancer among females in the world, and there are over 500,000 cases per year of new diagnoses of women that are diagnosed. And there's over 260,000 deaths per year. And so this remains a health crisis, especially in places outside of the United States. But here as well in my own practice, I diagnose several cervical cancers, some early and some unfortunately late stage in my practice every year. So the guidelines, the main update in the 2019 guidelines is that recommendations are based on risks, not results. So what does that mean? We used to have guidelines that were based very much on if this, then that. And while that is still true, while the patient's pap smear results matter, it's not so much just their results as much as the patient's kind of overall history. And so we use factors like age, prior results, and clinical factors to estimate in the app or in the web decision tool, if you're using that, the immediate and 5-year risk of CIN3. And this is an excerpt from the management guidelines. And what this says here is recommendations of colposcopy treatment or surveillance will be based on a patient's risk of CIN3 determined by a combination of current results and past history, including unknown history. Therefore, the same current test result may yield different management recommendations depending on the history of recent past test results. I think when I read this, as probably many of you did, and I know all of my residents and medical students who are with me in colposcopy clinic, everybody sort of feels, did they just make it more complicated? And so we're going to spend some time going over this and talking about what this exactly means. And we're going to talk about the 4% rule. So the question here is the immediate risk of high-grade dysplasia, CIN3, greater or equal to 4%? And most of our patients are going to fall down here in the no. And so if that's true, then we look at the 5-year CIN3 risk and find the surveillance interval. And again, we're going to know what the surveillance interval is by plugging the patient's information in, not just their most current pap test, but their prior results as well, into either the web-based decision or the app that you have on your phone. And that will tell us whether patients should return in a year if they have a greater than 0.55% risk of CIN3 at 5 years, return in 3 years if their risk is between 0.15 and 0.54, or return in 5 years if the risk is less than 0.15. So this is where most of our patients will be. If you have a patient who is up here, this is when things start to get serious, and either we recommend colposcopy if their risk is between 4 to 24%, expedited treatment, or colposcopy, meaning you could just do an excisional procedure right off the bat without a colposcopy, or just doing which is acceptable, or just treatment is preferred if the risk is extremely high. And again, these values, which box your patient falls into, will be when you plug your information in, when you plug the patient's information and their previous information into the app. So this slide is sort of just conceptually what patients fall into where, and there are exceptions to all of these rules. But in general, the immediate risk of CIN3 is around 25% if you have a patient who has an HSIL, an atypical glandular cell, which we'll talk more about, or an ascus-H. That's where I mentioned it's ascus, but cannot rule out high-grade lesions. So these are patients with high-grade results with a really serious risk of CIN3. Low-grade results, these are the patients who are mostly going to fall into our colposcopy category. Patients who are ASCUS but HPV positive with LSIL with unknown history, or HPV positive but with normal cytology 2 times 12 months apart. And then this category over here is really what has expanded in these recent guidelines. This is patients who you do not need to do colposcopy for. So if you have a patient with normal cytology but HPV positive, as long as it's just once, they don't need colposcopy. If that happens to them twice, then they get over here into the intermediate bucket and need colposcopy. If you have LSIL, but it's HPV negative, again, no reason to subject those patients to colposcopy. And if you're HPV negative ASCUS and you don't know the prior history, you can repeat that pap smear. They do not need colposcopy either. And again, if this all still feels a little bit muddled, we're going to talk through this a little bit more with the caveat that, these low-grade abnormalities but negative HPV test actually have a very low risk of needing colposcopy due to their low risk of high-grade dysplasia.
Dr. Gockley, before you move on, we do have a question here in the chat. Yeah. Someone is asking if you can speak to the evidence around HPV vaccine administration to women who have not previously received the vaccine but test positive for high-risk HPV.
Yes, absolutely. And you know what, I can just jump ahead because I'm really glad that that question has come up. I am on a vaccine crusade and trying to get more patients vaccinated because it is really important. So I'm actually just going to skip ahead to that at this point. So, vaccine for HPV is extremely important. It is available to both men and women up to the age of 45 now, and you can start this vaccine series as young as 9 years old. So that means if you have a 30-year-old in your clinic who has high-grade dysplasia and has not gotten HPV vaccine, she is still a candidate for it. Now, can it actually be therapeutic? This is something that a lot of us who take care of these patients and think about this a lot are very interested in. And there are 6 studies that include almost 3,000 women looking at surgical excision versus surgical excision with HPV vaccination. And the difference here in terms of recurrent high-grade or moderate grade dysplasia with and without the vaccine was notable. So 1.7% of women with the vaccine and excision had a recurrence compared to almost 5% of women who did not have the vaccine following their surgical excision. And so, there definitely more work needs to be done in this space, but I encourage all people who are eligible, so any humans in this category, 9 to 45, both men and women who have not gotten the HPV vaccine should get the HPV vaccine. I talk about these things over here too, that this is not just about cervical cancer, that the HPV vaccine actually can help reduce the risk of all of these other diseases, genital warts, non-genital warts, anal cancer, oropharyngeal cancer, a benign condition called recurrent respiratory papillomatosis, and penile cancer. So this is extremely important. The other thing that often comes up is patients will sometimes say to me, I had one HPV vaccine and then I kind of forgot, I moved, I lost my insurance, something happened, and what should I do? And so we do recommend completing the series. There is definitely some guidance that is still in flux about that, but at this point, if I can obtain coverage, I do recommend that all of my patients complete the vaccine. If you have a woman who is older than 45, I talk to them and say that this may benefit you, but I have no data to support that it will, and it will not be covered by insurance. And so that's a individualized discussion with each patient.
And then we have another question here asking, is there any evidence so far that HPV vaccine can help manage the infection similarly, to how Colpo can help resolve lesions?
I think that's part of what these studies are trying to figure out is, can the HPV vaccine actually change how the body is processing the HPV infection? Traditionally, what we have thought about this is that patients who get the HPV vaccine, what it does is it helps prevents them against new infections, but it doesn't do anything for the infections that they currently have. And I think that paradigm is evolving, and studies like, these 6 studies are definitely challenging that, but I don't think we have any great data right now to tell patients that it changes their current infection. We hope so and we think so, but the data is not there yet. Because here, if we go back up to that slide where we were talking about the dysplasia here, Once you have the HPV infection and the HPV DNA is integrated into the host genome, which is what's happening here, the thought is that the HPV vaccine does not stop that process. Now, there's some thoughts that maybe if the HPV vaccine is given when the virus is here before it's actually integrated into the host genome and before the dysplasia actually starts, that maybe that can actually slow or stall or even prevent the process. Any other questions about HPV vaccine at this point?
I don't see any right now, but if they pop
Okay.
up, I will let you know.
Great. We'll keep going here. I'm sorry for jumping around, but because that was so important and brought up, I just wanted to talk about that at this point. So let's talk a little bit about, sort of the classic case, and we'll go a little bit from here. So you have a 23-year-old G0 who presents to your clinic, and you would like to screen her for cervical cancer. So my first thing here is vaccine. Has she gotten it? If not, please give it to her. And then how do you decide to screen this patient for cervical cancer? So, we have cytology, we have co-testing, we have primary HPV testing. What do you use for her? And what the guidelines tell us here is that these patients should really be tested with cytology alone under 25. And that's really because the prevalence of HPV infection, especially in this population, is so high, and most of these patients will clear those HPV infections. And so really just cytology alone. And what we think about here is if they have ascus or LSIL, you can just repeat their cytology at 1 year or reflex to HPV at that point. And if they have these higher grade dysplasias like an ASC-H or an HSIL, those are the patients who need colposcopy. And then the HPV based testing really only comes in for women who are 25 years and older. So again, you'll see HPV in these guidelines for these young women, but it is a reflex. They should be tested with cytology alone. I have a lot of patients who get referred to me, 24-year-old with ascus or with, let's say, NALIM, but HPV positive. And those patients actually, we should never have known about their HPV because they do not have any cytologic abnormalities. So that's a big point here. Women who are younger than 25, cytology only, just use HPV for reflex testing for those patients. So the 5 clinical scenarios, and we're going to go through each of these, and this is really what in dysplasia clinic we do a lot of, and what's kind of the bread and butter of cervical dysplasia management. So you can have an initial management of an abnormal result, a return visit for surveillance of abnormal results that did not go to colposcopy, evaluation of colposcopic biopsy results, managing of test results less than CIN2, and follow-up after treatment of CIN2 and 3. So initial management of an abnormal result. So what really warrants us going to colposcopy? And we've said this a couple different ways, but again, for women under 25, those are really only your high-grade abnormalities, your ASC-H and your HSIL. They should go to colposcopy. And then for women who are 25 and older, if your CIN3 risk is greater than 4, which again, you're going to get by plugging the patient's data into your app or your the website, then you go to colposcopy. If the risk is less than 4, those patients are going to return in 1 to 5 years, depending again on how they fall out in terms of their risk stratification. So again, this is how we figure out who goes where. So this is the patient's returning in 1 to 5 years, depending on which box they fall into here. And again, it's hard. It's not like if this, then that. It's really more of a global assessment of each individual patient risk. But that's okay, because we're going to use the app or we're going to use the web-based guidelines, and it will be relatively quick and painless. Then what about the issue of managing a return visit for surveillance of abnormal results of a patient who didn't go to colposcopy? So these are your young women with these sort of low-grade abnormalities. We're going to repeat cytology at 1 and 2 years. If we are going to then eval a colposcopic biopsy result, we're going to have either a CIN1, 2, 3, or benign. If they're benign, then they're going to get follow-up, again, based on their prior risk factors. If you have a CIN1, that's a 1-year follow-up usually, although can sometimes depend on the preceding cytology. This is a very low-grade abnormality. I'm not very worried. 1 year is totally reasonable. If you have CIN2, your more moderate dysplasia, these are the patients that you can choose to either observe versus do an excisional treatment on, something like a LEEP or a cone. Who gets observed versus who has excisional treatment is something that we'll talk a little bit more down later through the discussion, but really depends on age and fertility goals, prior procedures, that sort of thing. CIN3 is basically a do not stop, do not collect $200. This patient must get treated. This is not something where there's really a lot of wiggle room. And then if you're managing the test result of a patient who has less than CIN2, these are patients who can have annual co-testing for 3 years and then can go back to routine surveillance. Again, this is CIN1 or less. And what happens after you treat CIN2 or 3? Once you've done your treatment, these patients then go on to HPV testing at 6 months or Colpo and ECC at 6 months. If they have positive margins, so this is someone who comes to you, they have high-grade dysplasia, you do a LEEP and one of the margins is positive. I quote those patients a 17% risk of persistence, and that's based on, again, the ASCCP guidelines from using the Kaiser Permanente data. And so you can consider either observing those patients closely or doing another repeat excision depending on their fertility goals. Annual HPV or co-testing, that should say, at 3 years, and then Q3 surveillance for 25 years. This is really important. Once a patient has fallen into this category of moderate or severe dysplasia, they never really get to go back for routine surveillance until they have completed 25 years of Q3 surveillance. They don't get spaced out to 5 years until they've completed their 25 years of Q3 surveillance. So primary HPV screening, we've probably all heard something about how it's so great. Maybe we don't need to do pap smears anymore. And I think that this slide is again from the guidelines and is a nice cautionary tale here. So primary HPV screening, yes, it's really good. It is very sensitive and very specific. You can get 3 different results from your primary HPV screening. 16 or 18 positive, those patients would just go to colposcopy because we know these are associated with 70% of our cervical cancers. And there's the 12 other high risks. So we often see these on pathology reports from our pap smears that they are other high risk positive. If you are doing primary HPV screening, you still need to do cytology because you want to find out, is this patient having a significant abnormality or do they have normal cytology? And that will help you know whether these other high-risk patients need colposcopy or just follow-up. And if your primary HPV screening is negative, then you can maintain the routine screening pathway, which if you are using primary HPV screening, the routine screening is between 3 and 5 years. Okay, vaccination, like we talked about, very, very important. All men and women from age 9 to 45 should be candidates, and a discussion should be had about the benefits of this. So who needs to come see me and my GYN oncology colleagues? So this really depends on what your scope of practice is, your resources, and what you feel comfortable with. All of us are happy to see any patient that doesn't really fit the guidelines. You plug them in, and sometimes the guidelines say, not enough information to know, or something about the exam that you don't feel comfortable with. All of us are happy to see these patients to really, do a full evaluation and help them get the appropriate care that they need. All patients with adenocarcinoma in situ should be seen by a gynecologic oncologist, regardless of their age. And we'll talk a little bit more about why that is later. Sometimes we see these results on histology or on cytology where they say it is either ascus or it's HSIL, cannot rule out invasive cancer. All of those patients need an evaluation by a GYN oncologist whenever possible to make sure that there isn't either cervical or some other kind of cancer that we're missing on their exam. The oddities concerning exams, all of these are also indications to kind of bump it up to us in the GYN oncology and the dysplasia clinic to see these. If you see a patient, let's say a woman who hasn't really had any gynecologic care for several years, and you think she may have a cervical cancer based on your exam, please be careful with biopsying these patients. These tumors are extremely vascular and there is a very high risk of hemorrhage. So unless you have a LEAP machine set up and the ability to do cautery in your practice setting, please be careful with these patients. And again, we're always happy to see them because we have those tools set up. And I just a couple weeks ago had a young woman like this who I biopsied, and we went through an entire box of scopettes. And so it is, the bleeding is really, really real. So you want to make sure you're in a situation where you're ready for that if you're going to do that. And pregnant patients who have an indication for colposcopy, they're usually best managed, again, with GYN oncologists or in a very experienced high-risk dysplasia clinic because they are a little bit more complicated, which we'll talk about in a moment. So what about the rare cytologies? Atypical glandular cells. So we sometimes see this on a pap smear, and the glandular cells is not something that we usually think should be present in a pap smear. And what do we do when we see those? These patients need a full colposcopy, endocervical curettage, and if they are over 35 and not pregnant, they need an endometrial biopsy. And the reason for that is I've diagnosed many women with endometrial cancer that have actual endometrial glands being detected on their pap smear because the endometrial cancer is sort of exfoliating cells down through the endocervical canal that are being detected at the ectocervix. And so when you see that, it should raise suspicion for endometrial cancer. If there's no cancer or CIN2 or greater identified, these patients can then have co-testing at 1 and 2 years. But this should sort of get your intuition up that something may be wrong, because this read is associated with a 3 to 4% risk of adenocarcinoma in situ and a 2 to 3% risk of invasive cancer. The other rare cytology is adenocarcinoma in situ. And like I mentioned before, these patients should really be sent to a GYN oncologist. They need a very complete colposcopy, ECC, and endometrial biopsy, again, if greater than 35 and not pregnant. And most of these patients, we consider doing a cold knife cone as opposed to a LEAP. And the real difference between a cold knife cone and a LEAP is that, the LEAP is more superficial. It just tells us what's going on the, most superficial part of the cervix, whereas the cone has some depth to it. The LEAP also uses electrocautery, which obscures interpretation of the margin, whereas a cold knife cone is, as it suggests, a cold knife that really the pathologist can orient and tell us very precisely what's going on in the margins. The reason why this is important for this histology is adenocarcinoma is associated with skip lesions. So sometimes you will see it, there'll be an area then deeper where it's not present, and then it will pop up again in the endocervical canal. So kind of a tricky one, and really good for a GYN oncologist to be involved in your management of these patients. And then following an excisional procedure, most AIS patients ultimately have a TLH or can be considered for fertility sparing if they are young and desire future fertility. So let's talk about some clinical conundrums.
Sorry, Dr. Gockley, before we move on.
Yeah.
We have another question here that says, when doing primary HPV screening, are the swabs endocervix or vaginal? Isn't the pathway less patient-centered at this time because a positive HPV test, especially in someone under 25, would lead to a second speculum exam?
I think I understand the question. So I always do these as part of my pap smear when I am sending them off. I do not do primary HPV screening because, again, I want to know what the cytology is. And so even if we move to a place where we're only looking at the HPV primarily, I still want to have cytology for these patients. So I try to do it so that even if they end up over here, we have the cytology result and I wouldn't need to repeat my exam, if that makes sense. And if it doesn't, please ask a question again, and I can make sure I'm answering your question specifically. So these are endocervical, collected the same way that we collect our pap smear with the cyto brush as well as the spatula. And then the idea is that when the fluid gets tested, they just test for HPV, but reserve the specimen in case cytology is needed at a later time. Okay.
They said, great, thank you. So I think that was perfect.
Okay, great. Good. Okay, so let's talk about pregnant patients. So Pap smears are safe in pregnancy. And I think that's something that most of us know, but every now and then I do still have, whether it's friends or family or patients being like, can I get a pap smear when I'm pregnant? Yes, they are 100% safe. And pregnancy is actually a really special time to capture women who may otherwise be behind on their screening. So please, please, please do pap smears on your pregnant patients. Colposcopy is safe in pregnancy as well. Looking, using the acetic acid, that is all safe. What is not safe is either an endocervical curettage or an endometrial biopsy. Please do not do this in your pregnant patients, as it does potentially put the pregnancy at risk. What about an excision or biopsy? So actually the ASCCP suggests that doing biopsies is safe, especially of the ectocervix. Again, not an ECC, not an EMB, but a biopsy of the ectocervix can be safe in pregnancy. Most of us in practice do not do it because, again, of that long time frame. Even if there is CIN3, the likelihood of it progressing to cancer during the pregnancy is extremely small. That being said, it is reasonable and acceptable and preferred, actually, to do a biopsy or an excision if you think there's invasive cancer there. And again, most of the time, if this is the sort of situation that you find yourself in with your patient, please reach out and, to your friendly neighborhood gynecologic oncologist and have them take a look at the patient too, because this is pretty high stakes and you want to make sure you're not missing a cancer, but also that you're not doing an unindicated procedure on their cervix. So definitely something to be wary of and think about. But I do sometimes biopsy pregnant patients because I want to make sure that we are not missing a cervical cancer in their pregnancy. If you do that and they have HSIL or CIN2-3 that is diagnosed at their first colposcopic exam during pregnancy, how do you manage them? These are patients who usually in the non-pregnant state, we would proceed right to doing a excisional procedure on, but obviously we just said that we only want to do that if invasive cancer is truly there. So if you don't think invasive cancer is there, but they do have this high-grade abnormality, they should undergo colposcopy every 12 to 24 weeks in the pregnancy. So I usually see people every trimester and then at 6 weeks postpartum. What about after they deliver? So postpartum colposcopy, really important public health note here. Almost, 15% of new mothers may lose their health insurance in the postpartum period. And so the postpartum period for most health insurance companies is defined as the first 6 weeks following delivery of the baby. And so this is another sort of golden window where if you don't get your moms in by 6 weeks, then it may not be possible to have them come back and to treat them effectively. So make sure you get that colposcopy in by 6 weeks. No earlier than 4 weeks because there are still significant changes happening in the cervix and the uterus. So if you do find yourself in this category, which we spoke about, where there's this high-grade dysplasia, you can excise at that same time. If you're really worried, you don't have to do another biopsy. You can just say, we know that you had CIN2-3 12 weeks ago. We're going to go forward and excise this. If no lesion is seen, you should still do a full diagnostic evaluation with co-testing and colposcopy. What about immunosuppressed patients? And this is really important because immunosuppression allows the proliferation of the HPV virus. And all of that timeline where we talked about how long it takes from HPV infection to mild, moderate, severe dysplasia, and eventually cancer. That timeline is much, much shortened in patients who are immunosuppressed because the normal immune mechanisms that we have to fight off these viruses do not exist in these patients. So these are not just your HIV patients. These are all of your solid organ transplant patients. These are allogeneic hematopoietic stem cell transplant patients, patients with SLE or IBD and rheumatologic conditions requiring immunosuppressive therapy. So make sure you have a sense of kind of what your patient's medical history is and what medications they're on to understand if they are or are not immunosuppressed. And the rules for these patients are different. And again, this is all in that guidelines. It's all available to you. But basically, you want to begin screening within the first year of insertional sexual activity, and they continue for their entire lifetime. So this is kind of the exception of no screening before age 21. If you have a 16-year-old who is an HIV patient or who is a stem cell transplant patient, they should get their cervical cancer screening. And if they are less than 30, you do cytology only. And if they are greater than 30, then you do cytology or co-testing and continue that. And then over here is sort of when to send for colposcopy. And basically, it's just that if have a lower threshold to send these patients for colposcopy. And oftentimes these patients are managed in our dysplasia clinic because they are trying to get cleared for a organ transplant, or they have had a history of dysplasia already. So a lot of these patients end up getting followed closely in dysplasia, but this is kind of the things that you want to think about for who's going to go for colposcopy. So LSIL or worse goes to colposcopy, and ASCUS HPV positive or worse goes for colposcopy. If you have ASCUS and no HPV testing, these are patients that you can repeat for cytology and then send only if their cytology is ASCUS or higher the second time around. So what about your young woman who is not pregnant yet, but she might want to be? So when you have a patient who has moderate dysplasia, so again, CIN3, not really optional, really should treat those patients. CIN2, what the ASCCP guidelines tell us about these women is that if their concerns for fertility outweigh their concerns for cancer, which I think if you ask many young women, that might probably be true, observation, if you can see the whole squamocolumnar junction and you have a negative ECC, is reasonable. That doesn't mean observation forever. That means observation with colposcopy and HPV testing at 6-month intervals for up to 2 years. If they never really clear it by the 2 years time point, then ASCCP says you really should treat those patients. And that treatment is usually by a LEEP or a cone. And how do I talk to patients about what the likelihood is of this actually regressing? And so there's a meta-analysis from almost 40 years of data here that looks at about 50% of CIN2 lesions regress, 32% progress, and less than 20% progress. And for women who are under 30, you can actually see an up to 60% regression rate. And so this is the data that the ASCCP is using to tell us, yeah, it is safe to observe these patients, but you just want to make sure that you're not missing these persistent and progression patients. One of the questions that always comes up is, if I have a LEEP for my CIN2, will I have preterm birth? Will I have preterm delivery? Will I be able to carry a pregnancy? Will I be able to carry it to term? And this is a really tricky one. The Cochrane Review has looked at this extensively, and what the Cochrane Review says is there's a lot of data, but a lot of the data is very low or low quality data. And so what I tell patients is it really mixed in terms of what your risk of preterm birth following excision will be. I say if we need this, usually I recommend preconception counseling with a maternal fetal medicine doctor to talk about if there are certain things that we need to consider doing to help support her in her pregnancy, but that at this point it is not guaranteed that just because she has an excision, she will or will not have a higher risk of preterm birth. Any questions about that? I feel like that comes up very frequently. All right. So just a couple more here. I want to make sure we have plenty of time in case there's other question or discussion points. What about patients after hysterectomy? If your patient had a hysterectomy with no prior CIN2 or worse within the past 25 years or completed her 25 years surveillance, she does not need further pap smears. So if your patient never had CIN2 or worse, or if she had it but has already completed her 25 years since then, you don't need to screen these patients. So the vaginal paps, just to have them to have the HPV, not helpful in these patients, okay? But it's different if you performed a hysterectomy, if your patient had a hysterectomy for actual treatment of dysplasia. For those patients, you need 3 consecutive annual HPV-based tests. And then the long-term surveillance is basically Q3 years for 25 years. So that 25 years is really important to think about for these high-grade and moderate dysplasia patients, that basically you need 25 years of dysplasia before you're completely, or 25 years of surveillance, excuse me, before you're off the hook for following these patients. So regular hysterectomy, don't do it. CIN2 or more, you have to get 25 years regardless of if you've had your uterus removed or not. And then what about a couple other conundrums, and then we'll open it up for questions. What about unsatisfactory cytology? This is annoying. This is when a patient may have to come back. So a negative HPV test from a co-test with inadequate cellularity on cytology should not be interpreted as negative primary HPV test and should be repeated. So basically, if you don't have enough cells, you can't really be sure that you have enough data to know about what the HPV result of your patient is either. And so it's really important to repeat those, and you're going to repeat that at 2 to 4 months. If you have HPV positivity, then you can go to colposcopy directly for these patients. But in general, think about age-based screening repeating in 2 to 4 months. Now, what about another similar but slightly different? If I have no evidence of intraepithelial lesion or malignancy, but I didn't get the transformation zone, you'll see most pathology reports actually note this on the cytology. And basically, if you don't have any transformation zone detected, then you really do defer to your HPV, which is again why most of our patients are getting that co-testing as long as they are 25 years and older, right? Okay, so just a little bit of a recap. HPV infection is common, but luckily dysplasia is rare. HPV vaccine is effective and safe from age 9 to 45 in both men and women. Our guidelines are now based on the risk of CIN3, both immediate and in 5 years. Women who are under 25 are managed by cytology primarily, as compared to women who are greater than 25 years who are managed by co-testing. Primary HPV testing is important, but does not negate cytology. And use the app or the website for management. Don't worry alone. Plug your patient's data in, and it will usually be very helpful. And my email is here, and I'd be more than happy to take any questions. And if you have specific clinical scenarios that you want to talk about, I'm happy to speak one-on-one as well. So thank you so much for your attention, and please let me know if there's any additional questions.
Thank you so much, Dr. Gockley. We'll just give everyone a minute to submit any questions that they have. And I don't know if you want to go back to the slide with your contact information. I will also be sending out an email to everyone following this. So if you do need to get in touch with Dr. Gockley for anything, you can absolutely email me directly and I can get you in contact, and I'm happy to set up a one-to-one if you need to discuss something in more detail. I would encourage you to submit any additional questions that you have either in the chat or the Q&A, and then we can go from there. Okay, I think we may have answered all of the questions because I'm not seeing any open ones right now. I think people had them as you were speaking
Yeah,
about
absolutely.
topics, which is really the best way to ask them.
Mm-hmm.
So
great. Well, thank you everybody for your attention. And again, my email is right here, and Elisa can definitely put you all in touch with me as well. So, question.
Sorry, yep, a question just popped up. If a patient has a PAP/HPV that should be followed up with a colpo, but have been lost to follow up, should they go directly to colpo or repeat co-testing?
Yeah, thank you, Anne. That's a really good question. So most of the time, I would say these patients should start back at the beginning and get co-testing because there's such a high likelihood of clearance of the HPV infection as well as the abnormality. You know, when we go back up here to the early slide where I showed the timeline here, so many of those abnormalities are actually going to completely disappear. I wouldn't just automatically colpo the patient. You know, colpo is very safe, it's very effective, but you know, it's uncomfortable and it's stressful for patients. And so for this kind of patient, I would definitely just start at the beginning and then manage based on the result that you had that she did not get follow-up for, as well as your most present result. I would put both of those in the app, and then it would tell you whether or not she needed colposcopy at the current time.
Perfect. Thank you. All right. I think that is it on the questions, but if later on you think of one, please feel free to email either myself or Dr. Gockley, and we will make sure that you know, someone gets back to you with them.
Excellent. All right. Well, thank you so much. I hope everyone has a wonderful evening.
Thank you so much, everyone. Have a great night.